I want to do is share with you a couple of videos that talked about a cardioversion. So many of you may not have seen a cardioversion. Here are a couple of vision. One, the first one is just a few minutes, and it talks about the cardioversion of atrial fibrillation. So hold on one second, and we'll take a look at this.
Emergency department management of atrial fibrillation is changing. In the past, the emphasis has been on simply controlling the patient's heart rate. Today, the emphasis is on not just controlling the ventricular rate, but also on converting the rhythm from atrial fibrillation back to normal sinus. This applies not just to unstable patients, but also to stable patients. Most patients who are converted from atrial fibrillation to normal sinus rhythm can be discharged from the hospital. For elective ED cardioversion, the patient episode of atrial fibrillation must be less than 48 hours duration, or the patient must be on some form of ongoing anticoagulation. To begin the process, the patient is placed on a cardiac monitor and an intravenous access obtained, just as with any other cardiac patient. The discharge is delivered through stick-on pads in most patients, although the normal paddles can be used in patients if these pads are not available or do not fit onto your cardiac monitor defibrillator system. Pads are placed generally in the anterior portion of the chest over the sternum, usually a little bit to the right, and the second pad is placed in the posterior part of the chest, just a little bit to the left of the midline, at about the level of the heart. The synchronized function on the monitor defibrillator is activated and usually indicated by a small mark over the QRS complex. This allows the system to determine when the shock should be delivered so it is not administered during the vulnerable part of the QRS complex, which might result in the production of ventricular fibrillation. The patient is sedated with any combination of procedural sedation agents. In many instances, propofol is selected, mainly because it is rapid acting, produces deep sedation, and some sense of amnesia for the events. Once the patient is sedated, the monitor is checked to make sure it is in the synchronized mode and sensing. It is charged to 200 joules. There is no need to start at lower energy levels and titrate up. 200 joules is used for both atrial fibrillation and atrial flutter. The operator needs to confirm that no one is touching the patient, and the monitor may be discharged by pushing an activation button. The button will have to be held in place as the monitor must sense the QRS complex to determine the proper time to deliver the shock. Generally, the patient will jump somewhat when the shock is delivered. Successful cardioversion is confirmed through observation of normal sinus rhythm on the cardiac monitor. The patient is observed in the emergency department until all signs of procedural sedation have cleared. Patients who remain in normal sinus rhythm can safely be discharged from the emergency department after an hour or so of observation. Most patients who are successfully cardioverted will remain in sinus rhythm and can be discharged home with no additional medications for follow-up with their cardiologist.
Okay, so as I was looking at the video, I saw in the chat there's some great questions, and I'm going to address those questions. The last video, as you see, shows how an elective cardioversion goes. This is very likely the procedure that J.J. Watt underwent. Again, the reports are that he underwent cardioversion, a shocking of his heart. So essentially what's done, you start an IV, you give some conscious sedation. When I've done these, I have an anesthesiologist, and yes, they'll use propofol. Many of you may remember that propofol was what was used with Michael Jackson, but that was in his bedroom, and that's not the appropriate place to use propofol. But in a medical unit where you have an anesthesiologist and all the emergency equipment you need to take care of a patient, if something goes wrong, it's the ideal place for it. We've used it. I've used propofol when I was a fellow in the CCU many times, and it's a very effective medication and can be used safely in the proper setting with the proper backup. So once the patient's sedated, as you saw, there's a cardioversion. Now, notice he mentioned that you have the little synchronization, so you get those little spikes on the QRS. And with an elective cardioversion, when you shock, you want to make sure it doesn't shock on a certain part of the QRS, because you can put one in a life-threatening arrhythmia called ventricular fibrillation. So you don't want to do that. And so when this situation goes on, then you have a nice, happy, as we call it, happy cardioversion. Typically, the patient gets out in one shot, and after that, they are doing pretty well. You let them recover, wake up, and then everything's done. Now, I want to show you one other video where there's an emergent cardioversion. And they call it emergent. I should say urgent. It wasn't really emergent. Emergent cardioversion is not cardioversion. Emergent is when, well, you can have an emergent cardioversion if somebody's in an AFib and the blood pressure is very low. They can still be awake somewhat. The blood pressure is very low because it's compromised, and they're in cardiogenic shock or decompensating rapidly. So that could be emergent. But typically, when you're shocking someone in an emergency, it's not a cardioversion, but it's it's not a synchronized cardioversion, but either an conversion of ventricular fibrillation or something like that. But the supraventricular arrhythmias are usually urgent or elective. And the ventricular arrhythmias, when you're defibrillating someone as opposed to cardioverting them, is when they're in VFib arrest and you're doing CPR. I'm not going to show you that video, but here's an interesting video from an emergency room cardioversion. It's a few minutes, but I think it's worth looking at. And then once we come back from this video, I'm going to answer your questions, and we're going to talk about how we can wrap all this stuff up and give you some pointers in terms of A, how to prevent atrial fibrillation, and B, if you have atrial fibrillation, how to naturally reverse atrial fibrillation. So stay tuned. And as we get ready to go to this video, if you haven't done so, hit the thumbs up button, show us some love, and share this, and subscribe if you haven't had a chance to do so.
A lot of times it does, so we'll be.
As long as they're in the course of it,
Yeah, these are important educational tools. So we've tried, Charlie. What have we done so
we
far?
tested 6 and 12 with adenosine. We did 24 along with vagal maneuvers here with no success.
No success. Okay.
All right, we're gonna sit you back, okay? All right. Now this is gonna be a little uncomfortable, okay? That's the nice way to put it. The real way to put it is it's gonna feel like somebody hit you in the chest with a baseball bat, okay? And hopefully we won't have to do this for once. All right. How are you feeling?
Got it already, or you need it, or reverse it? Just right now.
I'll give you 30 seconds or so.
You might need some, that's impressive.
Put this back on you, okay?
Okay, so you need the Versed, or you got the Versed? Got it already, okay.
Yep, sorry. Put this on. All right, Charlie. How are you feeling? I'll put this back on you here. Okay, thank you. Okay? Okay. All right, here it comes, sir.
Trying to. Okay, bud. You're doing good. Good, buddy.
You doing all right?
You working?
All right.
Okay.
All right.
When a plan comes together, don't get cardioversion.
He was kicking it, she said he's better.
We didn't sedate him completely because of his low blood pressure.
Correct.
You doing okay, Mr.
Now
Bailey?
our heart rate's holding. Cycle that pressure. We're gonna put it done, please.
There you go. 101/66.
Mr. Glenn, you're doing good now.
You doing all right?
Yeah.
Yeah.
You okay?
How you feeling?
You can relax. You
Relax.
totally fine. I know.
At
That's
least
that verse.
he's not gonna
Trying to
remember.
eat that pulse off. Everybody likes to eat the pulse off.
You're all right. All right.
All right, Charlie. What else you want?
It's okay. You're doing good.
How you feel?
A little before and after. You doing okay? Good.
Relax back.
Sorry about that, but problem's fixed, okay?
Now.
So make sure that he hasn't infarcted. You have to make sure that there's nothing.
His electrolytes.
Electrolyte abnormality. You gotta make sure he's not infected. you gotta make sure. I mean, I don't think he's withdrawing because it's been 3 weeks. He's not he was a little hyperdynamic heart rate, but his blood pressure was fine. So
But
you
he
look
did
for
say he'd
everything
been
else.
having a little bit of hallucinations, and
What now?
he did say he had had some hallucinations and been like this for 4 days, so maybe he's DT.
Yeah, so maybe.
He's
He
done
had
this-
next to where he was sitting a bucket about that full of vomit too.
Okay, well there you go. So you gotta work him up. You know, just search for everything. You know,
No, he's not either.
and you know, look for his guidance 1.8. I don't know what it's based on.
Well, I must have done one now.
I'm
Yeah.
sorry, but
And then see if he's in there. Look for the old stuff. You know, pour. You know, give him some fluids. I would give him some Ativan now. I would give him some multivitamins. I'll give him some diamonds for like. You know, I'm not big on banana bags, but and then just X-ray.
can you relax for just a minute? Put your arms down by your side.
Get one more EKG, honey.
But I think you know the
You're
back
doing
the back part
good.
now is
Can you
not.
relax your arms?
That's pretty impressive heart rate.
So what we have here is a situation where a gentleman's in the emergency room and he comes in this arrhythmia, and it's really a supraventricular arrhythmia. And I was able to see the tracings during the arrhythmia. It looks like an atrial tachycardia. Now I'm not 100% certain, but if I can see it, and I froze it a little bit. And the reason I think it's atrial tachycardia is what we call a long RP tachycardia. That's one. Two, they gave him adenosine in 6 milligrams and 12 milligrams. It didn't convert. You don't convert atrial tachycardia with adenosine because the circuit is isolated to the upper chamber. Adenosine works in the AV node area. And so and the facts of the long RP tachycardia could be an atypical AV nodal retention tachycardia or AVRT or atrial tachycardia. Excuse the medical jargon, but I think that was an atrial tach. Plus, they pointed out this gentleman consumed alcohol regularly. Apparently, it recently stopped, but may have been in DTS. So alcohol heart syndrome typically can cause atrial fibrillation or atrial tach. Other stressors include, steroids or ischemia, smoking. A lot of these things can trigger anything that can cause electrolyte imbalance. They were talking about magnesium imbalance, things like that, potassium, other oxidative stress, increased oxidative stress. Excuse me. Alcohol is an oxidative stress agent, bad food, processed sugars, etc. Some people ask some interesting questions. Somebody asked about the jab. I don't know necessarily if that has something to do. They have to come to our private channel and hear more about that. Let's see here. There was a question about, I wanted to take, they talk about the injection. Magnesium. Now, there's a great point about magnesium. What I want to say about magnesium is there are a lot of people who are magnesium deficient, and individuals have things like insomnia, headache, fatigue, anxiety, cardiac arrhythmias, can all be associated with magnesium deficiency. And when you check your blood level of magnesium, it may be normal, but you still may have total body or tissue level magnesium that's abnormal. Magnesium is primarily an intracellular or a tissue-bound ion electrolyte. And it's really hard to just screen for magnesium deficiency. You have to have a high clinical suspicion. People who are on diuretics, or if you drink a lot of caffeine, that may have a diuretic effect. You may be deficient in magnesium. If you take drugs like proton pump inhibitors, they can reduce your magnesium absorption. Different peptides and things like that. Someone asked a great question, does aspirin help? Now, if you look at the old data of individual with chronic atrial fibrillation where they did the warfarin trials, warfarin versus placebo was clearly a benefit of warfarin. So people with chronic atrial fibrillation with associated risk factors had a benefit with warfarin. If you looked at warfarin compared to aspirin, and now if you looked at 81 milligrams of aspirin versus warfarin versus placebo, there was really no benefit with aspirin. There was one trial, however, when you used 325 milligrams of aspirin. So it was placebo, nothing, aspirin, 325 milligrams, and warfarin. Warfarin was significantly improved, better in terms of reducing stroke, but aspirin was better than placebo in that group. So there was at least one trial that showed some intermediate benefit of aspirin, even though it was inferior to warfarin. Hello, Pepper Goddess. How many times can a person have a cardioversion? That's a great question. I don't think there's an absolute upper limit. I've shot individuals multiple times, certainly in an emergency situation, 10, 15. We've been in situations and, in defibrillator implants, we've had 40, 50 shocks. People get shocked 50, 60, 70 times with defibrillator. So there's not an upper limit. Granted, you get skin burn and things like that. But I've seen many shocks or cardioversions depending on the situation. There are a number of people ask about the COVID shot. I won't address that due to the YouTube algorithm. But if you, what you should do is go to our private channel where we talk about some of these things. So we, hold on one second here. On our private channel, we will cover a number of these things. I'm gonna give you MontgomeryHeart.com. I'm going to make a banner out of this. I'm going to put it in the chat. But you go there, sign up for our private channel. It really supports our research. It's a very modest cost per month. Join the inner circle. And the reason I suggest that is because we can talk about things. I can answer questions of this type without being scrutinized. So I'm going to share that with you on the banner. So go to MontgomeryHeart.com journey, and you can find out about, these kinds of questions that are very sensitive. It would be too sensitive to cover in this setting. So join our online community. Thank you, Jackie. We put the link there. Also, William, Mr. Bespoke Bibbs, I exercise 4 days a week, don't drink, smoke, or do drugs, but have had a cardioversion twice and possibly a third. Yeah, it's possible to do a lot of the right things, and it could be some other things you need to do. Maybe check your magnesium level. You may need to be on a magnesium supplement. Make sure you check your diet and make sure it's an optimal, nutritionally optimal diet. But we work with a lot of people with atrial fibrillation. It can be a little bit tricky. But if you had the cardioversion that's keeping you out of sinus rhythm, then certainly that's a good thing. Keeping you in sinus rhythm, that's a good thing. So I think that's something that you should consider. But certainly look at your diet. Make sure you're not consuming alcohol to any extent. And be careful with the caffeine. Caffeinated beverages of any type can predispose you to atrial fibrillation. So all these things are very important. And these are all great questions. But J.J. Watt converted from atrial fibrillation. Godspeed to him. And hope things continue to go well with him for the season. He's a great athlete. He was a great asset when he was in the Houston community. And I'm sure he's a great asset to the community that he's in with the Arizona Cardinals. So Godspeed to him. That's all I have for you tonight. Thank you very much for joining us. And this has been a great show. Thank you for your participation. Spread the word. If you hadn't had a chance to, hit the like button. Always share this information. And if you hadn't had a chance to, please subscribe. But until next time, keep it fresh, natural, and live.